Good afternoon. Hope everybody's still awake after those exciting hot topics. They are a great setup for the next discussions about restoring vision. And of course, we all ideally want to preserve vision so people with diabetes don't need to have their vision restored. But in reality, Dr. Brian Vanderbeek has shown that at least half of the patients who've had successful treatment for their DME or their PDR still have subnormal vision. And besides trying various anti-VEGF agents and various combinations or steroids and even controlling their diabetes doesn't restore their vision. So there's still another half of the equilibrium to be addressed. And in fact, when Robert first kicked off the first workshop on this topic in 2017. He called it the Restoring Vision Moonshot, realizing that it was going to take a big, hairy, audacious goal and a lot of people and a lot of money. It was about restoring vision, whether with retina chips or gene therapy or pharmaceutical agents or whatever's come along. So we have two exciting talks today. The first one is by Dr. Leonard Levin, who is a neuro-ophthalmologist, and part of the bigger picture here, Len, come on up, is learning from the lessons from other diseases, such as Dr. Goldberg discussed with glaucoma. All right, and now it's a real pleasure to welcome Dr. Steve Tsang from Columbia University, who's going to take his hat off to us.
So thank you, Tom. So I'll tell you in three parts. One, the oxidative stress and oxidative radical probably contributes to diabetes and lead to the death of retinal pigment epithelium. And then we show you how the replacing those retinal pigment epithelium. And then the last part is the laser panel. And then the last part is to show you how it applied to proliferative diabetic retinopathy. So this is just like Len to show you a case. This is a typical diabetic patient that come to see me. The patient was referred for the workup for EBC for Stargardt with a 20/150 vision and 20/40 vision. This is a fundus finding. If any of the fellows can give the diagnosis, we can move it a little faster on the residents. So the patient still have a central, the patient do have type 2 diabetes. The patient have good central foveal cones in the left eye, and the right eye is 20/150 because most of the cells are gone now. In this particular case of diabetes, it affects the epithelium long before the photoreceptors. You can see that the left eye can still see some cones in the OCT. In the left eye, you can see outer nuclear layer. You can also see the ellipsoid zone in the left, but the right eye is gone now. We typically do electrophysiology. You can see that it's essentially pretty normal. So it only affects the central macula. This is not so uncommon. We have these patients come on a monthly basis. This is just a different patient. In this case, the patient still see 20/20 on both eyes. This is just one of the GI doctor just recently retired, and also even though the side vision is not too good, he can still continue to do endoscopy. So this is if anyone wants to suggest a diagnosis, these are the differential diagnosis, including macular degeneration, the pentosin toxicity. The patients referred for Stargardt ABCA4. It can be also due to a form of pattern macular dystrophy. CRB1 crumbs can have normal ERG, as shown in this patient, and a prominent one also. So this patient we refer to us because for Stargardt we do the DNA sequencing. Result was negative the first round. Any suggestion what this could be? So it has one mutation in CRB1. Anybody agree with the diagnosis? So we look at the blood because of maternal inherited diabetes and deafness, negative. Then on the urine sample, we can discuss later why the urine would give a better yield. The patient has maternal inherited diabetes and deafness, and leads to the death of the early death on the retinal pigment epithelium and later on photoreceptors. So epithelium is actually replaceable. Previous slide. So this is almost like bringing coal to Newcastle, radish and using cell suspension from a cell line from cadaver eyes. You can establish the retinal pigment epithelium, and this shown some of the phase 1 2A encouraging result using RPE transplantation. In this case is for another epithelial disorder, macular degeneration. So there are many, currently quite many, as you heard from Len, there are many different sources. You can make epithelial cell, we can use an induced pluripotent stem cell, as shown here, typically made from blood. You can also use embryonic stem cells as well from the inner cell mass. So these are applied mostly in macular degeneration. Of course, this can be applied for this maternally inherited diabetes and deafness cases also. So either in the case that you can do it as a cell suspension, you can also do it more matrix. The cells are polarized. It's a little bit early to say which one would give better results. So suspension has the surgery, the delivery is easier than a sheet. So this is some of the early transplantation. This is done with fetal cells, first done by Pythagoras. You can see the little dots the patient initially can fixate, but after a while the patient lost fixation because of rejection. So this is just a different graph. This is in the little dots. The white dot shows that the patient can fixate in the first week, but over time, at 3 months, the patient lost fixation. The graft is being rejected. We also show proof of principle to apply it to another RPE disorder, deficiency in this retinal isomerase, RPE65. The patient cells have, the donor cells from people have pigment, and then the mouse is albino, also has this RPE65 defect. So we can see that the transplanted graft can incorporate. And so this is a typical transplant, and then you can see double layer of the RPE in the first few days. In about a month, you can see 2 layers of the retinal pigment epithelium with the arrows shown in here. This is another case, an albino, and then the graft also double layer. And we get functional back. The blue is the graft, and then the black one is the control, and the mutant, say the fellow eye or the control is the red traces. So we have improvement, focal patch lead to global improvement on electroretinogram responses. So because of this, there's many, in the context of time, just run through this quickly, there are many trials. Most of the trials are allogenic in nature. And there's a full page of trials, either induced pluripotent stem cell, or those are embryonic stem cell trial ongoing all over the world, mostly for macular degeneration, some for retinitis pigmentosa. And also recently, in the last maybe 3-4 months, Fuji and Blue Rock also get approval for phase 1 trial doing photoreceptor transplant. So that's in relation to diabetes. We got some vitreous sample from Vinny Mahajan from Iowa State Prison. So patients have very high level hypoxia-inducible factor. If you overexpress hypoxia-inducible factor in mice, we can get proliferative diabetic retinopathy changes. The mice get vitreous hemorrhage. You get neovascular iris. You get neovascularization of the disc. So also you can see this severe non-perfusion. The flat mount is a mouse. The angiogram is a human. And you can see neovascular tissue. So we work with, we got some hematopoietic stem cells from Maria Grant. And then these stem cells are put in the vitreous. You can see and they tend to home around the optic nerve. And then you can see that they also seem to home around the vasculature. So I think they seem to last a long time, also in the lifetime of a mouse. So show you some example using regenerative medicine approaches. Most of the trials is on retinal pigment epithelium. Certainly can be applied to maternal inherited diabetes and deafness, and also some of the many trials now for macular degeneration, replacing the retinal pigment epithelium. And also stem cells can also seem to home in the vasculature in a proliferative diabetic mouse model. So we first thank the mice, the volunteer, the lives for the project. We got the GFP marked cells from Maria Grant, and this the diabetic proliferative diabetic mouse model was generated by a previous graduate student. Now she has her own lab in UT Southwestern, Katie Worth. And I'm happy now to take questions.
Go ahead.
Oh, thanks. Super interesting, and clearly a lot of data you have on cell therapy for RPE-specific diseases. And at the end of your talk, you alluded to translating a lot of the information to cell therapy for diabetic population. Can you just expand on that a little bit more, like what's being done, cell therapies for diabetic population, because it's obviously a different cell type than for the RPE cell therapies that are already kind of in log phase?
So we should, the hematopoietic stem cells seem to be able to home just by putting in the vitreous. It seems to home around the vasculature. So in principle, in diabetic retinopathy, with damage to the endothelial cells or the parasite, maybe those can be replaced by. We have done using Maria Grant's hematopoietic stem cell, but you can also envision that IPS the stem cell IPS ES cells can also make endothelial cells or parasites, and they can also seem to somehow home in the disease vasculature.
Great talk. Thanks for including our work, Dr. Tsang. What, in the case, to amplify that question earlier, the neural component of diabetic retinopathy, do you think there's a role for cell replacement or trophic components when the inner retina is atrophic in late disease, or in PRP and the outer retina is affected? Patients may have constricted visual fields. What the neural component of the diabetic retinopathy or diabetic retinal disease, do you think there's a role for cell therapy? And if so, which cell type beyond the endothelial cells?
So some of you can take maybe some of the lessons coming out from photoreceptor transplant. So photoreceptor transplant, people seem to be suggesting efficacy. Maybe all it does, the photoreceptor cell, although some progenitor cells just making lots of lactate. So that will be able to support the lactate production or some trophic factor from photoreceptors seem to either make rod-derived cone viability factor or lactate, and they seem to suppressing the epithelium to do glycolysis, and then it helps the cones. So maybe some of the a similar story in the astrocyte also makes lots of lactate. So some of the neural cells maybe doesn't need to, as Len said, maybe not so challenging to require them to connect. If they make lots of lactate, maybe that's enough. And that may account for some of the efficacy seen in some of the recent either intravitreal retinal progenitor cells or the subretinal retinal progenitor cells, getting some improvement without any connection.
Earlier today, we talked about the path from laboratory science to clinical trials and the challenges of that. How should we think about that, and particularly since we have lots of people from pharma here, about the attractiveness of stem cell therapies for DRD?
So if they can restore endothelial cell vascular function, maybe they will see less leakage or less improved perfusion as a potential outcome measurement. If it is neural function, then all the things we heard about, like electrophysiology or microperimetry, those are potential for neural function.
Mm-hmm. Thank you very much, Stephen. That was terrific.